Hip fractures are among the most common injuries in orthopedic trauma, accounting for about 20% of the operative workload. They are associated with very high morbidity and mortality, reaching up to 10% within the first 30 days. Beyond survival, they also carry a major impact on quality of life and life expectancy. It is important to highlight that femoral neck fractures make up more than half of all hip fractures. The lifetime risk of sustaining a hip fracture is significant, approximately 40 to 50% in women and 13 to 22% in men. With the aging global population, the incidence of hip fractures continues to increase, rising from about 1.6 million cases in 1990 to a projected 6.26 million cases by 2050. When we look specifically at intracapsular hip fractures, which are the majority, around 15% are undisplaced. Historically, these cases were almost always treated with fixation. However, this approach is now under debate as large randomized trials are comparing fixation with arthroplasty. The majority of intracapsular fractures are displaced and tend to occur in elderly women. Treatment options include reduction and fixation, cemented or uncemented hemiarthroplasty, and total hip arthroplasty. National registries show wide variation in practice. Importantly, recent evidence suggests that arthroplasty is the superior option for most displaced intracapsular fractures, though fixation may still play a role in younger patients with good bone quality. Epidemiologically, femoral neck fractures are most frequently seen in elderly female patients. According to the National Hip Fracture Database, about 59% of all hip fractures are intracapsular. These fractures are rare in patients younger than 60 unless associated with high-energy trauma or poor bone health. The risk of sustaining a second hip fracture within 2 years is considerable, about 10% in women and 5% in men. And if a patient suffers a second hip fracture, the mortality risk is the same as for the first, around 70% at 1 year. Now, let's turn to the risk factors. They can be divided into non-modifiable, modifiable, and secondary causes. Non-modifiable risk factors include age, sex, ethnicity, and family history. Modifiable ones include body weight, smoking, alcohol intake, level of physical activity, and diet or nutritional status. Secondary causes are important to remember for exams. These include chronic conditions like diabetes, renal disease, liver disease, endocrine disorders such as hyperparathyroidism, and medications such as corticosteroids, proton pump inhibitors, and long-acting progestogens. One key exam fact: each standard deviation decrease in femoral neck bone mineral density increases the risk of fracture by about 2.5 times. That's why osteoporosis and low bone mass are at the center of hip fracture pathophysiology. In addition, risk of falls must always be considered. With aging, patients are more likely to present muscle weakness, abnormal gait, balance problems, deteriorating vision, or neurological disease. These factors, combined with bone fragility, make hip fractures so common in the elderly population.
Next, we arrive at one of the most critical sections, the classification of intracapsular hip fractures. Several classification systems have been proposed, but the two most widely used are the Garden classification and the Pauwels classification. Both focus on different aspects. Garden emphasizes the degree of displacement, while Pauwels considers the inclination of the fracture line and the shear forces involved. Let's start with the Garden classification, first described in 1961. It divides femoral neck fractures into 4 types, based on how displaced the fracture is on the anterior-posterior radiograph. Garden 1. This is an incomplete valgus-impacted fracture. The trabecular lines remain aligned, and the medial cortex is intact. It is considered relatively stable. Garden 2 is a complete fracture, but still undisplaced. The trabecular lines remain collinear, and the femoral head is not shifted. Garden 3. This is a complete fracture with partial displacement. The trabeculae and the femoral head are no longer aligned with the acetabulum, but the fracture is not completely separated. Garden 4 is a completely displaced fracture. The femoral head is no longer in any alignment with the acetabulum, and there is total disruption. In figure 53.4, you can see the 4 Garden types clearly illustrated with radiographs and diagrams. Type 1 shows the valgus impacted fracture. Type 2 demonstrates a complete but undisplaced fracture. Type 3 reveals partial displacement with trabecular misalignment. Type 4 shows complete displacement, the most unstable form. Clinically, Garden 1 and 2 fractures are often treated with fixation, while Garden 3 and 4 are usually treated with arthroplasty, especially in elderly patients. A key exam pearl: inter-observer reliability of the Garden classification is not very strong, and surgeons may disagree on whether a fracture is 1, 2, or 3. Now let's discuss the Pauwels classification. This system is based on the angle of the fracture line relative to the horizontal plane on the AP radiograph. It essentially measures how vertical the fracture is. Type 1. The fracture angle is less than 30 degrees. Type 2. The angle is between 30 and 50 degrees. Type 3. The angle is greater than 50 degrees. The more vertical the fracture line, the greater the shear forces across it, and the higher the risk of fixation failure and nonunion. In figure 53.5, you can see these 3 Pauwels types illustrated schematically. Type 1 with a shallow horizontal fracture, Type 2 with a moderate slope, Type 3 with a steep vertical fracture, where shear forces are maximal. Vertically oriented fractures, especially Pauwels type 3, are more common in younger patients with high-energy injuries. Unfortunately, these fractures have traditionally poor outcomes with classical fixation methods, and advanced techniques may be required, such as using buttress plates to counteract shear forces. When studying for exams, always remember, Garden equals degree of displacement. Pauwels equals angle of the fracture line. Both systems complement each other, and together they guide treatment decisions.
Now, let's discuss the Orthopedic Trauma Association, or OTA-AO, classification. This is a comprehensive system that classifies all long bone fractures using an alphanumeric code. For femoral neck fractures, the code is 31B. The B1 group represents undisplaced fractures. The B2 group includes transcervical fractures, which run through the middle or base of the neck, and the B3 group covers displaced subcapital fractures located just below the femoral head. Within these main groups, there are further subdivisions. B1.1 and B1.2 describe valgus-impacted fractures, with differences depending on whether the valgus angle is greater or less than 15 degrees. B1.3 includes non-impacted fractures. The B2 subgroup describes different patterns of midcervical fractures, such as adduction or shear types. Finally, the B3 subgroup describes subcapital fractures with increasing degrees of displacement, such as varus angulation, vertical translation, or both. You can see all of this illustrated in figure 53-6, which shows the different subtypes schematically. This is useful for exams, but in clinical practice, the system has not been widely adopted because inter-observer agreement is poor and it does not reliably predict treatment or outcome. Moving forward, let's highlight an important radiographic parameter: posterior tilt. This refers to the posterior angulation of the femoral head relative to the neck measured on the lateral radiograph. Surgeons measure the angle formed between the midline of the femoral neck and the central axis of the femoral head. Why is this important? Studies have shown that a posterior tilt greater than 20 degrees is associated with a significantly higher risk of fixation failure. In fact, one meta-analysis of over 10,000 patients found that posterior tilt above 20 degrees nearly tripled the risk of needing reoperation after internal fixation. Take a look at figure 53-7. It shows how this angle is measured. The reference lines are drawn through the femoral head and neck. The posterior tilt angle is then calculated, and values above 20 degrees predict instability and worse outcomes. Now let's move to the outcome measures for femoral neck fractures. Since most of these injuries occur in elderly patients with comorbidities, it is not enough to only look at radiographic healing. Clinical outcomes such as mobility, independence, and quality of life are extremely important. Mortality and unplanned reoperation remain the most commonly reported outcomes in the literature, but researchers also use several functional scores. The New Mobility Score, or NMS, evaluates independence in activities such as walking indoors, walking outdoors, and shopping. It ranges from 0 to 9, and lower scores predict poorer recovery. The SF-12 and EuroQoL EQ-5D are validated questionnaires that measure overall health status and quality of life. There are also hip-specific scores, like the Harris Hip Score, the Oxford Hip Score, and the Charnley Score. These are more detailed but also more time-consuming to use. For daily function, simple scales such as the Barthel Index and the Activities of Daily Living scores can be used. Another very practical test is the Timed Up and Go test, or TUG test. In this test, the patient is asked to stand up from a chair, walk 3 meters, turn around, walk back, and sit down. A time greater than 12 seconds is associated with poor mobility and high fall risk. Finally, in geriatric patients, even physical fitness can be tested with the chair stand test, where the patient sits and stands repeatedly for 30 seconds. The number of repetitions gives an idea of lower limb strength and endurance. The key takeaway is that femoral neck fractures are not just about bone healing. For elderly patients, recovery is measured in terms of independence, mobility, and quality of life, not just radiographs.
Now, let us shift our focus to the pathoanatomy and applied anatomy of femoral neck fractures. This is a crucial section because understanding the underlying anatomy is the key to explaining why these fractures behave the way they do and why their treatment can be so complex. We begin with the skeletal anatomy. The hip is a classic ball and socket joint, and in the case of the femoral neck, 2 important anatomical parameters influence biomechanics: the femoral neck shaft angle and femoral neck anteversion. The normal neck shaft angle averages around 130 degrees in men and 128 degrees in women. If this angle is less than normal, it is called coxa vara. If it is greater, it is called coxa valga. Anteversion refers to the angle between the femoral neck and the transcondylar axis of the knee, usually between 15 and 20 degrees. Variations in these angles can influence the mechanical stress applied to the femoral neck and thereby the risk of fracture. Another critical concept is the hip axis length. This is the distance from the lateral aspect of the greater trochanter along the axis of the femoral neck to the inner table of the pelvis. Longer hip axis lengths are associated with a higher risk of femoral neck fractures. Interestingly, this perimeter is generally longer in white females than in Asian or Black populations, which may contribute to the observed differences in fracture incidence. If you look at figure 53.8, you can see an illustration of the hip axis length and the neck shaft angle. Notice how a longer hip axis length results in greater lever arm forces being transmitted to the femoral neck during a fall. This is why geometry alone can predispose to fracture. Now, let us turn to the blood supply of the femoral head, one of the most clinically relevant aspects in this discussion. This is especially important because disruption of blood flow is the main reason for complications such as avascular necrosis after intracapsular fractures. The vascular supply comes from 3 main sources: extracapsular vessels, intracapsular vessels, and vessels within the ligamentum teres. Of these, the most important is the medial femoral circumflex artery, or MCFA. This artery runs posteriorly around the femur and gives rise to the retinacular vessels that ascend within the capsule toward the femoral head. These branches, particularly the superior retinacular arteries, are the lifeline of the femoral head. If they are torn during a displaced fracture, the risk of avascular necrosis increases dramatically. In figure 53.9, you can see the detailed vascular anatomy. The extracapsular arterial ring is formed by the medial and lateral femoral circumflex arteries. From this ring, the ascending cervical arteries rise along the neck and penetrate the capsule in the retinacula of Hueter. They ultimately supply the subchondral bone of the femoral head. The foveal artery, a small branch of the obturator, also contributes, but mainly in children. It regresses with age and is rarely sufficient in adults. The clinical importance of this anatomy cannot be overstated. After a displaced intracapsular fracture, revascularization depends on whether these retinacular vessels survive. If they are torn, the femoral head becomes ischemic, predisposing to nonunion and avascular necrosis. This is why surgeons are so cautious about the choice between fixation and arthroplasty in elderly patients with displaced fractures. Now, let's move to the ligaments of the hip joint capsule. The capsule extends from the acetabulum to the intertrochanteric line anteriorly and the femoral neck posteriorly. It is reinforced by three strong ligaments: the iliofemoral ligament, also known as the Y ligament of Bigelow, which resists hyperextension; the pubofemoral ligament, which limits abduction and extension; and the ischiofemoral ligament, which resists internal rotation. These ligaments stabilize the joint but also constrain surgical exposure. During fixation of intracapsular fractures, the tightness of the capsule and its attachments influence the ease of reduction and implant positioning. Next, let us consider the sensory innervation of the hip. The joint receives sensation from multiple nerves: the obturator, femoral, sciatic, and superior gluteal nerves. The anterior capsule is mostly innervated by the femoral and obturator nerves, while the posterior capsule is supplied by branches of the sciatic. This explains why pain from a hip fracture is often poorly localized, and why nerve blocks, although helpful, may not always provide complete relief. Finally, we must not forget the muscles surrounding the hip. The flexors include the iliopsoas and rectus femoris, both inserting near the lesser trochanter and anterior femur. The abductors, mainly the gluteus medius and minimus, stabilize the pelvis during gait. The external rotators, such as the piriformis, obturator internus, and gemili, are particularly relevant in surgery because surgical approaches often require their detachment or protection. In the context of fractures, muscle forces can also influence displacement. For example, in an intracapsular fracture, the pole of the iliopsoas tends to externally rotate the femoral shaft, while the gluteus medius abducts the proximal fragment. This explains the typical clinical deformity of a shortened, externally rotated leg.
The overwhelming majority of these fractures occur in elderly and often frail patients. A minority of cases occur in younger adults, usually as a result of high-energy trauma, such as road traffic accidents. These younger patients represent a distinct group with different operative considerations, and we will cover them separately later. For most patients, however, the challenge lies in the frailty of both bone and patient. This is why shared care models involving orthopedic surgeons, anesthetists, and geriatricians have become the standard of care in many countries. The goal is not only to fix the fracture, but also to address the patient's overall medical condition and optimize recovery. Let us begin with the admission assessment. Every patient presenting with a hip fracture should undergo a structured evaluation upon admission. This includes the history of the fall, which is essential. While many of these patients will have simply tripped or slipped, it is crucial to rule out acute medical conditions such as stroke, arrhythmia, or syncope that may have caused the fall. Cognitive function, tools like the AMT4, can rapidly screen for confusion and delirium. Remember, pre-existing cognitive decline or dementia is common in this population, and delirium is one of the most feared perioperative complications. Medical comorbidities: cardiac disease, atrial fibrillation, respiratory problems, and diabetes all play major roles in guiding perioperative risk. For example, atrial fibrillation may delay surgery if the patient is on anticoagulation. Respiratory disease must be evaluated carefully, especially if the patient struggles with breathlessness during minimal exertion. Another key aspect is frailty assessment. The Clinical Frailty Scale, or CFS, is widely used. Figure 53.2 in this chapter shows the 9-point scale. Patients who are robust, active, and energetic score as very fit or well. Those with controlled medical problems but less activity are classified as managing well. Patients with slower mobility and reduced independence are classified as mildly or moderately frail. At the severe end, patients who are completely dependent or approaching the end of life are classified as severely frail or terminally ill. Frailty scores directly influence decision-making. Fit patients, CFS 1 to 3, are expected to recover well, and the goal is to return them to full independence. Moderately frail patients, CFS 4 to 6, are at greater risk but may still benefit significantly from surgery. Severely frail patients, CFS 7 to 9, are at very high risk, and the decision-making shifts towards quality of life, dignity, and end-of-life care discussions. Now, regarding perioperative care, the guiding principle is simple. Early surgery saves lives. Studies consistently show that operating within 24 to 36 hours reduces mortality, complications, and delirium. Delays beyond this window increase the risk of poor outcomes. However, surgery must be balanced with optimization. Certain medical conditions must be corrected before anesthesia. Hemoglobin below 80 grams per liter, sodium or potassium outside safe limits, severe uncontrolled heart failure, active chest infection or sepsis, or uncontrolled diabetes with ketoacidosis. These are considered reasons to delay, but otherwise, surgery should not be postponed. Perioperative pain management is another cornerstone. Hip fractures are extremely painful, especially with movement. Inadequate analgesia leads to distress and increases the risk of delirium. The standard approach includes regular paracetamol, sometimes combined with opioids in frail patients. Nerve blocks, such as femoral nerve blocks or fascia iliaca blocks, are increasingly used and can reduce pain scores significantly. Let us now discuss the postoperative care. Rehabilitation must begin immediately after surgery. The principle promoted by the Fragility Fracture Network is everything out, everyone up, every day. This means that patients should be mobilized daily, encouraged to sit out of bed, walk, and resume functional independence as quickly as possible. Key aspects include nutrition. Malnutrition is common and must be corrected with protein supplements and vitamins. Anemia. Early transfusion may be necessary if hemoglobin drops below 80 grams per liter. Falls prevention. The fracture is often a marker of frailty and osteoporosis. Secondary prevention with vitamin D, calcium, and anti-resorptive medications should be initiated in the hospital. Delirium prevention. Mobilization, adequate hydration, and minimizing opioids are essential. The use of delirium screening tools like the 4AT test helps early recognition. Finally, the goals of care must always be individualized. For some patients, the aim is a rapid return to independence. For others, especially those who are severely frail, the realistic goal may be pain relief and dignity rather than prolonged aggressive treatment.
Let us now review the treatment options for femoral neck fractures. We begin with non-operative management. This is rarely used today, but it can still be considered in very specific cases. For example, in undisplaced fractures in extremely frail patients who cannot tolerate surgery, or in situations where surgery is not possible due to comorbidities. Patients treated non-operatively may be mobilized with touch weight bearing using crutches, and healing can occur within 4 to 6 weeks. The main advantage is that it avoids surgery, but the problem is the very high risk of displacement. Studies have shown displacement rates ranging from 19% to as high as 46%. This means that almost half of patients initially managed without surgery will later require operative treatment. To give you examples from the literature, Hansen reported displacement in 10 out of 16 cases treated non-operatively. Cohn Parker showed that nonunion was twice as common in conservatively managed patients compared to surgically treated ones. Some series reported secondary displacement occurring as late as 24 weeks after injury. So the key takeaway is Non-operative treatment is rarely appropriate except for the most frail patients or those with undisplaced fractures who cannot undergo surgery. Now let us move to the operative treatment, which is the standard of care. The first decision to be made is whether to use fixation or arthroplasty. Fixation is generally reserved for younger patients and for undisplaced fractures. Arthroplasty, either hemiarthroplasty or total hip replacement, is recommended for displaced fractures in elderly patients. Before surgery, we must consider anesthesia and perioperative management. There has been a long debate over spinal versus general anesthesia. Large trials show little difference in mortality, but spinal anesthesia may reduce pulmonary complications, whereas general anesthesia can be safer in patients with contraindications. Blood loss is another concern. The average blood loss in hip fracture surgery is around 1 liter. Tranexamic acid has been shown to reduce transfusion requirements and is now commonly used. Now let us focus on the surgical approaches. Anterior Smith-Petersen approach. This is the classical anterior approach to the hip. The incision runs along the iliac crest, extending toward the anterior superior iliac spine. The gluteal muscles are detached from the anterior iliac crest, and the plane is developed between the sartorius and the tensor fascia lata. This gives direct access to the anterior aspect of the joint. It is particularly useful for open reduction of femoral neck fractures, but is less commonly used for arthroplasty. Anterior Hueter approach. This is a more limited anterior exposure, popular for hip arthroplasty. The incision is placed between the sartorius and tensor fascia lata, and the rectus femoris is retracted medially. A T-shaped capsulotomy is made to access the femoral neck. The key advantage of this approach is preservation of muscle integrity, making it less invasive. Anterolateral Watson-Jones approach. This uses the interval between the tensor fascia lata and gluteus medius. It provides good access to the anterior capsule and is often used for femoral neck fracture fixation. However, it is less ideal for arthroplasty because stem placement can be challenging. Direct lateral hard-hinge approach. Here the incision runs over the greater trochanter, splitting the gluteus medius and minimus. This provides excellent exposure for arthroplasty and is one of the standard approaches for hemiarthroplasty and total hip replacement. The main risk is injury to the superior gluteal nerve, so careful dissection is required. Posterior approach. This is the most widely used for hip arthroplasty. The incision is made posterior to the greater trochanter, splitting the gluteus maximus and detaching the short external rotators. It gives excellent access for implant placement, but carries a higher risk of post-operative dislocation. Surgeons usually repair the capsule and reattach the short external rotators to reduce this risk. Each of these approaches has advantages and disadvantages, and the choice depends on surgeon preference, patient anatomy, and the procedure being performed. Fixation versus hemiarthroplasty versus total hip replacement.
Let us now focus on internal fixation of femoral neck fractures. For most patients with undisplaced intracapsular fractures, fixation remains the treatment of choice. The main implants used are cannulated screws or a sliding hip screw. In modern orthopedic practice, cannulated screws are usually preferred because they allow for a minimally invasive percutaneous technique. If you look at the blue box with the key surgical steps, you can see the sequence. The patient is placed in the supine position on the operating table. A traction table and fluoroscopy are used to confirm fracture position. A short longitudinal incision is made just below the greater trochanter. Guide wires are inserted into the femoral head, usually 3, under AP and lateral fluoroscopy. The wires are then over-drilled and cannulated screws are inserted over them. The screw length and position are confirmed with final X-rays. This procedure has the advantage of being minimally invasive with little blood loss, and it allows early mobilization. However, outcomes depend heavily on implant placement. There has been long debate about how many screws to use and what their configuration should be. Most surgeons use 3 screws, often in an inverted triangle configuration, 2 superior and 1 inferior. Some evidence suggests this may provide the best biomechanical stability, but overall, meta-analyses have not shown clear superiority of one arrangement over another.
In figure 5311, you can see radiographs of healed fractures fixed with cannulated screws and with a sliding hip screw. Notice the 3 parallel screws in AP and lateral view, and the SHS with an anti-rotation screw in another case. Both methods can work, but some studies suggest that sliding hip screws may carry a higher risk of avascular necrosis compared to cannulated screws. The literature comparing these devices is extensive. For example, the FAITH trial randomized over 1,000 patients to SHS versus cannulated screws. The conclusion was that there is no clear difference in terms of union, reoperation, or avascular necrosis. The choice, therefore, often depends on surgeon preference and patient anatomy. That said, there are important nuances. In younger patients, especially those under 60 years, the goal is always preservation of the femoral head. This means fixation is preferred even for displaced fractures, as long as bone quality is good. In older patients, particularly over 65 or 70 with displaced fractures, the risk of nonunion and avascular necrosis after fixation is very high, often exceeding 30 to 40%. For these patients, arthroplasty, either hemiarthroplasty or total hip replacement, is generally the better option. Now let us discuss outcomes after fixation. The risk of failure after internal fixation remains significant. Nonunion and avascular necrosis occur in up to 20 to 35% of displaced fractures, depending on patient age and fracture type. Late collapse of the femoral head is a feared complication. This is why so many surgeons are cautious about attempting fixation in elderly patients with displaced fractures. Another key point is the role of arthroplasty even in undisplaced fractures. Some authors have argued that because fixation carries a risk of reoperation, arthroplasty may be preferable in older patients even if the fracture is undisplaced. However, the evidence is mixed, and most guidelines still recommend fixation for undisplaced fractures. When it comes to displaced fractures in young adults, things become even more complex. These injuries usually result from high-energy trauma, often with a vertical fracture line corresponding to Pauwels type 3. Because shear forces are very high, the failure rate of standard screw fixation is unacceptably high. In this setting, surgeons often use alternative constructs such as a fixed angle device or a sliding hip screw with anti-rotation support. Some centers also use medial buttress plates to counteract shear forces. Finally, let us emphasize an important technical note. Reduction quality is critical. A poor reduction, even with perfect implant placement, has a very high risk of failure. This is why so many authors advocate open reduction rather than relying only on closed percutaneous techniques, especially in young patients with vertical fractures.
In this part of the lecture, we will move beyond the basics of femoral neck fractures and focus on advanced treatment strategies, special situations, and the management of complications. We will discuss how displaced fractures are handled, how fixation techniques compare with arthroplasty, what happens in younger versus elderly patients, and finally, we will go through the main complications, such as infection, nonunion, avascular necrosis, prosthesis dislocation, and thromboembolic events. Reduction and fixation of displaced femoral neck fractures. When dealing with displaced femoral neck fractures, the goals are very different compared to undisplaced ones. Reduction and fixation are technically challenging and the complication rates are higher. In the table shown in the image, we see the outcomes comparing fixed-angle devices and independent screws. Notice how fractures with technical errors, such as inadequate screw length or poor reduction, have a very high rate of fixation failure. This highlights one of the most important points for exams. Reduction quality is the single most important predictor of success. The surgical technique box summarizes the key steps. The patient must be in supine position, no forceful reduction should be attempted, and intraoperative fluoroscopy is crucial. Anatomic alignment is judged on AP and lateral x-rays, with the goal of restoring the normal trabecular pattern. One useful concept here is the Garden Alignment Index, demonstrated in the diagram.
On AP view, the trabecular lines should make an angle between 160 and 180 degrees, and on lateral view, around 180 degrees. If the reduction falls outside this range, especially into varus, the risk of failure increases dramatically. In the illustrations provided, you can see how proper alignment creates smooth trabecular arcs, while malalignment produces sharp or broken curves. This is a very practical intraoperative sign and is often cited in exam questions. Postoperatively, patients are often kept with limited weight bearing for weeks, but in reality, many elderly patients cannot comply with touch weight bearing instructions. For this reason, some studies have explored early weight bearing, though the results remain inconclusive. Arthroplasty for displaced fractures. The next big question is whether to fix or replace. Several randomized trials and meta-analyses have shown that arthroplasty generally leads to lower reoperation rates compared to fixation, especially in patients over 65 or 70. We divide arthroplasty into hemiarthroplasty, where only the femoral head is replaced, total hip arthroplasty, or THA, where both the head and the acetabulum are replaced. The images show different implant designs. Historically, unipolar prostheses like Austin Moore and Thompson were common, but nowadays modern cemented or bipolar designs are preferred, since they reduce acetabular wear and the risk of dislocation. Evidence suggests that THA provides superior functional outcomes compared to hemiarthroplasty, especially in active elderly patients. However, hemiarthroplasty remains popular because it is technically easier and quicker with lower dislocation risk. A very important exam pearl. When the acetabulum is diseased, such as in rheumatoid arthritis or osteoarthritis, THA is mandatory. Special situations. Let us now discuss special scenarios. Ipsilateral femoral neck and shaft fractures. These occur after high-energy trauma, often in young adults. The radiographs shown demonstrate plating of the femoral shaft combined with screw fixation of the neck fracture. This is a technically demanding situation. Options include separate fixation with screws plus a plate, or combined devices such as reconstruction nails. Femoral neck fractures in rheumatoid arthritis. Due to severe osteoporosis, fixation outcomes are poor. In these patients, arthroplasty is usually the best solution. Stress fractures. These account for around 5% of femoral neck fractures, often seen in young female athletes and military recruits. On X-ray, fractures on the tension side or superior cortex are unstable and need internal fixation. In contrast, fractures on the compression side or inferior cortex are more stable and can often be treated conservatively with protected weight bearing. Paget's disease. These patients have abnormal bone metabolism and deformity, making fixation unreliable. Arthroplasty is preferred, but technically demanding. Metastatic disease. When the femoral neck fracture is secondary to carcinoma, fixation is contraindicated. Arthroplasty, usually THA, is the treatment of choice. Complications. A. Infection. The infection risk is generally lower with internal fixation compared with arthroplasty. Modern series report infection rates around 1 to 2% for IF and up to 5 to 6% for arthroplasty. Deep infection after arthroplasty can be devastating, often requiring prosthesis removal. Debridement and retention may work if the organism is sensitive, but many cases require full revision surgery. B. Fixation failure and nonunion. Failure is common in displaced fractures, with rates up to 30%. Nonunion is more likely when there is varus malreduction, poor fixation, or osteoporosis. In younger patients, salvage options include vascularized bone grafts, such as fibular grafts, or valgus osteotomy. The illustrations of the Meyer bone graft show how a posterior approach is used, elevating the quadratus femoris and inserting a cortical bone block to support the femoral head. This is a classic salvage technique for nonunion.
Avascular necrosis. AVN is a hallmark complication of femoral neck fractures. It occurs more frequently in displaced fractures, with rates up to 15 or 20%. It usually appears late, between 1 and 3 years after surgery. On the image of the valgus osteotomy, you see how altering the biomechanics of the femoral neck can help offload shear forces and reduce the risk of collapse. For exams, remember, AVN risk is higher in displaced fractures, lower in undisplaced fractures, decreases with increasing patient age because the bone is less viable but also less active. Prosthesis dislocation. This is the most common reason for revision after arthroplasty. The risk is higher in THA than in hemiarthroplasty. Reported rates are 2 to 6%. Surgical technique, implant choice, and patient factors all influence risk. Deep venous thrombosis and pulmonary embolism. Finally, we must not forget the systemic complications. Hip fractures carry a high risk of thromboembolic disease. Without prophylaxis, up to 50% of patients can develop DVT, and 5 to 10% may have pulmonary embolism. Current guidelines recommend low molecular weight heparin or fondaparinux for at least 28 days postoperatively. Aspirin is sometimes used, but evidence suggests LMWH is superior. Outcomes and prognosis. To conclude, the outcomes of femoral neck fractures depend heavily on patient age, fracture displacement, quality of reduction, and comorbidities. Undisplaced fractures treated with internal fixation generally do well. Displaced fractures in the elderly are best managed with arthroplasty to reduce reoperation rates. Younger patients with displaced fractures should undergo reduction and fixation whenever possible, but salvage techniques may be required in case of nonunion or AVN. So, in summary, femoral neck fractures remain one of the most challenging injuries in orthopedics. The surgeon must carefully balance between fixation and replacement, always considering the patient's age, activity level, and bone quality. For exams, focus on the classification systems, reduction quality, complications like AVN and nonunion, and the indications for arthroplasty versus fixation. This closes our advanced discussion on femoral neck fractures.